Welcome to Pharmacy Friends, a podcast dedicated to bringing industry experts to the same table to talk about what's happening in pharmacy today, what's coming, and most importantly, what it means to you.
Part of the value proposition is the new evidence of GLP-1s being the first drug therapy for the treatment of obesity that has shown a cardiovascular risk reduction.
I think GLP-1s are going to be one tool for the patients that can take them and afford them that's going to be helpful, but it's not going to eliminate obesity until we get to some of the root causes of obesity.
In this episode, Weight Management, a Holistic Journey, you'll hear from Dr. Pat Gleason, Assistant Vice President of Health Outcomes at Prime Therapeutics, and Dr. Dariush Mozaffarian, a cardiologist, public health scientist, and director of the Food as Medicine Institute at Tufts University. We discuss Prime's 4 primary tenets of practice for chronic weight management, ensuring any recommendations are rooted in clinical evidence, focusing on improving patient adherence and persistence to treatment, and driving value. Good morning and welcome to the Pharmacy Friends podcast. I'm Maryam Tabatabai, your podcast host. I'm grateful to be joined by Dariush Mozaffarian and Pat Gleason. Gentlemen, can you tell me a little bit about yourselves?
Well, I'll go first. Wonderful to be here, Maryam. This is Pat Gleason. I'm an Assistant Vice President of Health Outcomes here at Prime Therapeutics. I'm also a pharmacist and an adjunct professor of pharmacy at the University of Minnesota College of Pharmacy.
Yeah, really nice to be here with both of you. My name's Dariush Mozaffarian. I'm a cardiologist. I have a doctorate in public health, and I'm director of the Food as Medicine Institute at Tufts University, which is an institute dedicated to integrating nutrition-based holistic interventions into healthcare.
Wonderful. I'm excited to have both of you join me this morning on this exciting podcast. So for some context for our listeners, a few months ago, we published an evidence-based clinical white paper. This is part of our Clinical Insights series, where we looked specifically for this one at weight management as a holistic journey. There's a lot of emphasis on GLP-1s, right? So we wanted to understand that comprehensive view, not just the drug. And so we distilled our perspective, if you will, into 4 primary tenets that guide our practice around chronic weight management, specifically looking at evidence, right? Ensuring that any recommendations are rooted in the evidence, focusing on improving patient adherence and persistence to treatment, and driving value and advocating for responsible access to meds while still considering the total cost of care, and then that our approach is truly as holistic. We published the white paper, I believe, back in May. And then we also have posted 2 podcast episodes called The Skinny on GLP-1s, where we cover topics from drug information and pipeline and social media to real-world evidence and management strategies. So Pat, I know you were a guest on one of those podcasts, some really interesting conversation. So I share all this context for our listeners, in particular, as we continue our dialogue on this really important topic. And so our focus today is on holistic chronic weight management. Let's dive in. So I think first I'd like to talk about where GLP-1s are headed, right? It seems to me that drug development it's moving at lightning speed, right? What does the future of obesity and GLP-1s look like? Pat?
The future in GLP-1s is very bright, both for weight management and for diabetes. As we now have 2 specific GLP-1s in the marketplace, we expect more, and we expect more and more evidence of their benefits in weight loss and other treatment of of weight loss and the conditions that weight loss lead to and the damage that they do to your body. So I see continued use of GLP-1s for weight loss and more use.
Dr. Mozaffarian, any insights?
Yeah, I think, there's a few really key core points for the GLP-1s, I think I would emphasize, and we can talk more about each of these. But I think for the future, first, they're effective drugs for people that can take them. The average weight loss in real life from, large analyses of electronic medical records is about 10 or 11% of weight loss, which exceeds anything that's been seen before. I think there's a few really important caveats or concerns. First, most patients, as you guys have shown, are not still taking these drugs 1 year after prescription. And so side effects, costs, other things, most people can't continue to take the drugs. Number two, they're still much too expensive. They're never, I think, going to be cost savings unless they're $50 a month or something, but they're not even cost effective right now compared to other treatments. And so they're much too expensive, and we can talk more about that. But I think third, I think maybe most importantly is, these drugs are effective, but they're not going to eliminate obesity. Obesity is such a tremendous problem in our society right now. And so, even if you can take them, even if you don't have side effects, even if you can't afford them, the average weight loss, again, is around 10%. 1 in 11 adults in the United States today weighs over 300 pounds. And so if all of those adults were able to take this drug and lose 10% of their body weight, that's tremendous. That's wonderful for their health, but they'll still weigh 270 pounds or more. And so, we're still going to have an obesity problem. So I think GLP-1s are going to be one tool for the patients that can take them and afford them. That's going to be helpful, but it's not going to eliminate obesity until we get to some of the root causes of obesity.
I really appreciate that perspective. And I don't know if you saw the American Heart Association presidential advisory. They were looking out at the year 2050. Did you see that?
Yeah, so this was a nice modeling study estimating, where we're going to go and what the future is going to look like. And for example, they estimated that by 2050, 60% of adults will have high blood pressure and 60% of adults will have obesity. Now, I don't know that we need these modeling studies to 2050 because we are right now completely drowning in cardiometabolic diseases. We don't even have to look to the future. I mean, today in the United States, half of all adults have diabetes or prediabetes. 3 in 4 adults have overweight or obesity. And if you add blood pressure and blood cholesterol levels, 14 out of 15 adults don't have optimal cardiometabolic health. And so the vast majority of American adults are walking around sick. And most of that is from poor nutrition, as well as lack of physical activity. And so poor lifestyle is making the vast majority of Americans sick today. And this starts young. And so among teenagers today, 1 in 4 teenagers have prediabetes, 1 in 4 have overweight or obesity, and 1 in 6 have fatty liver disease. And so we have literally, are killing ourselves from our lifestyle. And the vast majority of Americans are sick. And so we have to really decide if this is the right way to spend our resources on expensive treatments, remediating these conditions once they've occurred, versus taking care of the underlying environmental issues that are causing these problems.
And so I guess with all that in mind, then what's the value prop, right? You've got the future, and then you have these alarming, really staggering numbers that you just shared. What's the value proposition for GLP-1s, and how does that tie into chronic weight management?
Part of the value proposition is the new evidence of GLP-1s being the first drug therapy for the treatment of obesity that has shown a cardiovascular risk reduction in the SELECT study published in the New England Journal of Medicine this past fall. First time. We've had many medications FDA approved for the treatment of obesity. They've been approved based on their evidence for weight loss, but they lack that evidence that they can prevent the bad things that obesity leads to. We now have evidence, like I said, in the SELECT study, at least for the subset of individuals that are overweight with pre-existing heart disease and don't have diabetes, that when treated for 3 years and adherent to their therapy, there's a reduction in those major adverse cardiovascular events like heart attacks. We soon may have an indication here in this month, even for semaglutide, Wegovy for heart failure as well. So as we look to the future, these products will potentially even have more indications. Sleep apnea has high potential, as an example. But to Dr. Mozaffarian's point, affordability is a real concern. The price of these products in the thousands of dollars a year of treatment, and the numbers of people that we know we need to be treated and will benefit from the therapies are very concerning.
Yeah, and I want to add to that. So, So first, I'm going to talk about a lot of concerns and caveats on this podcast about GLP-1s, around cost, around side effects, and also around equitable access. You know, these are not equitably accessed across your society due to these issues. But I'm going to talk about those concerns, but I want to echo what Pat said and what I said at the beginning, is these are effective drugs. These are the most effective drugs for obesity that have ever been developed. And because obesity has so many downstream negative consequences, all of those are improved with taking these drugs if you can stay on them and afford them and effectively lose weight. And so, you know, diabetes, cardiovascular disease has now been shown, very likely, you know, these other conditions such as obstructive sleep apnea and other things. And also, given their impact on the brain, potentially helping certain patients with more addictive behaviors around alcohol or nicotine, that some evidence is coming out around that. And so there's a lot of things that these drugs help with. At the same time, there is a broad misunderstanding. I've talked to doctors, I've talked to policymakers, I've talked to patients. There's a broad misunderstanding that because we know obesity is so expensive as a disease condition for our nation, that these drugs will be cost savings. And that is just, they're far too expensive for that to be true. So even if you take into account all of these downstream benefits of the cost of obesity, the drugs are not cost savings, and they're not even cost effective using traditional cost effectiveness thresholds. And I'll just leave you with leave this comment with one number to keep in mind. Right now, just for the weight loss eligibility criteria, let alone diabetes, cardiovascular disease, and these other ones that are going to emerge, there's 93 million American adults that meet just the weight loss eligibility criteria. At full discounted prices are around $6,000 or $6,500 per year right now. If all eligible adults receive the drug at discounts, the annual cost would be $600 billion, which is equal to all other U.S. prescription drug spending combined. And so, and Senator Bernie Sanders put out a nice report around this from the Senate on this cost. So these drugs will bankrupt the healthcare system unless they are dramatically reduced in price.
Yeah, and I'd like to circle back to that cost piece in a little bit as well. Yeah, and you know, so I guess as you continue to kind of talk about the value prop, what about mental health, right? We've talked a lot about the physical health aspect of things, and you know, from our white paper research too, one of the things that I learned is that there are higher rates of obesity that have been observed in individuals that have different mental health disorders, depression, bipolar disorder, ADHD, and others as well. Any thoughts around impact on mental health?
I believe there's be positive impacts, especially as you just stated, Maryam, as well as, you know, someone who's just weight. They're going to have a more positive body image. They're going to have more positive feelings about themselves, and that's important. And you know, I think that as we look at obesity, it isn't just the prevention of diabetes, future diabetes, the prevention of heart conditions, but it's about an individual's thoughts about themselves, their image, their mental health as well.
So I agree. I think that given obesity's downstream negative consequences on mental health, for most people, there will be a net mental health benefit. At the same time, I want to raise something that has just been, you know, more case reports than any real science, but I certainly have had several folks directly, you know, to tell me about this, is that because of the major action in the brain of GLP-1s reduce sort of risk-taking and kind of addictive types of behaviors. There are also several stories I've heard of people who take the GLP-1s and their personality changes in a kind of a negative way for those around them. They used to be boisterous, laughing, you know, really fun people, and they just sort of become muted. And I've heard that now many times. And then a second story I heard is someone who has a very high performing person on a high performing business board, where risk taking and thinking about you know, doing things that for business and for innovation, for entrepreneurship, needs that kind of cutting edge mindset. And they've changed, and their personality has changed, and they don't have that same drive. And so I think as we consider potentially, 100 million or 200 million Americans being eligible for these drugs and being on these drugs, what that's going to do to, beyond the benefits, what that might do in the negative aspects around the natural human need to want to take risks and do things that are a little bit crazy to have success, I think is a really interesting question. But I just want to turn back before we leave the value proposition. I think maybe the biggest fundamental value proposition that these drugs have created are two things. One, that really obesity is now recognized as a disease. That has been recognized by some associations, but for centuries, people have thought of obesity as just lack of willpower. You're just not able to do what you need to do, and it's your fault. It's the individual's fault. Now that we know that there's hormonal abnormalities that can be treated, people recognize obesity is a disease and can be treated. And I think that is a positive change for understanding and addressing obesity, not just through medications, but through a range of other efforts.
That's all really interesting. I'm glad you brought up that piece about recognition of obesity as a disease. I've heard others kind of ask me about that as well, and certainly as we've looking at guidelines and evidence. And so no, I really appreciate you bringing that up. And that piece that you talked about some of those case reports, if you will, or examples of some of the negative aspects as well, is a great segue to some of the barriers, right? I'd love to kind of understand what some of the challenges are. Some you've already mentioned, but what are some of the other challenges with GLP-1s? Pat?
Yeah, part of the challenges are affordability, as we've said, and the fact that for a lot of health insurance, it's not a part of the covered benefit. So just access. And as we change our mindset there as to the coverage, then we have to consider when you open that door and that gate, Dr. Mozaffarian said, the numbers of people that are going to then potentially use a GLP-1 and that given cost, needs to be put into consideration, as well as we think about those individuals who do start therapy. What is it about that therapy that's going to help them stay on that therapy? Because the new real-world evidence that we've been a part of generating here at Prime Therapeutics has shown that at year one, roughly a third of individuals appear to be taking their GLP-1, and then at 2 years, most recently, only 1 in 7 or 15% are still on therapy. So a halving of the population still on therapy from 1 to 2 years is concerning, and there's a number of reasons for that. We can get into that, but part of the barriers is helping people stay on the therapy.
And do we know the why, Pat? Why there are poor adherence persistence numbers as you look out 1 year, and as your health outcomes real world data has now shown 2 years out?
We didn't ask that question in our analysis. We really just wanted to get the answer out there as to what does the data say around individuals and that were commercially insured with coverage in their health benefit for the GLP-1 for the treatment of obesity. But we can speculate. As we all know, there's considerable adverse effects from these medications, especially on their the gastrointestinal tract, and nausea, vomiting, tolerance just to be able to take it. As we know, these medications are a dose titration over time. Can speculate that people might be trying to increase their dose too quickly, having side effects, giving up, maybe not getting to the weight loss that they expected to, and therefore no longer continuing taking therapy. There is an out-of-pocket cost, and so therefore a combination of maybe adverse effects and the cost, and people are selecting and lack of maybe effectiveness to choose to stop before they can truly get to that higher dose and receive the benefit. We know there have been shortages in the marketplace, so this could be what we're seeing as people appearing to no longer be taking therapy based on the claims data, because they can't get to it. They want to continue, but they just can't obtain product. There's another potential reason in that we may be misclassifying them as discontinued their therapy, non-persistent, because they've chosen to have the therapy compounded at a pharmacy, maybe because of the shortages issues, and or they've gone to purchase directly from the manufacturer. So lots of potential reasons, Maryam, for the finding we have. And lastly, I'll end with, they may have obtained the weight loss that they wanted to get to, successfully made changes in their diet and exercise, and have therefore discontinued therapy, which is a good thing. And once again, that would be a misclassification of someone who we say is discontinued when we wanted them to maybe be on therapy. But if they had that weight loss that they shot for and they made it and discontinued, that's great.
Really interesting. So we talked about, the value prop and some of the barriers, right? So what's missing from the conversation, right? Dr. Mozaffarian?
Well, I think when we think about some of the barriers, first, and to I think complete that a little bit, as a physician who also studies public health, I kind of have a foot in each camp, and so I recognize the value of the healthcare system and sort of the acute need to treat people when they're really sick, and how great that is, and the value of thinking sort of long term about how we handle health as a nation. And we are really dramatically overestimating in the first and dramatically underestimating in the second. Both are important, but we're not leveraging both. And the reason that's important, when you get back to these statistics about the usage of long-term GLP-1s, it's not that different from the long-term usage of many other drugs, some of which have very few side effects. And so somehow in the clinical realm, we as doctors, as healthcare policy leaders, as pharmaceutical companies, as pharmacists, we've gotten into our heads that people can't achieve lifestyle change long term, because when you do lifestyle change studies, only some people can do it long term and most can't. But what's really important to understand is when you look at pharmaceutical prescription studies, the exact same numbers are seen. And so I'll use the example of statins. Statins are one of the most well-studied, well-tolerated drugs with clear benefits that we have. They're very inexpensive now with generic drugs. And yet, if you look at statin prescriptions for primary care, at 1 year, only 30% of people who are prescribed a statin are still taking it at 1 year for primary prevention. And so people just don't like to do anything. It's hard for any of us to do something regularly. I get antibiotics for 10 days, and I get lucky if I can get to day 7, before I have to give up. And so I really want to emphasize that these long-term compliance issues, whether it's drugs, whether it's lifestyle, are challenging when we put it all on the individual. And so we really have to think about systems changes, about public health changes. And so it may not even be that unique to GLP-1s that it's 30% at 1 year and 15% at 2 years. That's just what people do when they have to do things long term. But I do think it's a real challenge, because weight loss plateaus by about 12 to 18 months in most people and doesn't continue. And so I've spoken to and heard about many patients who their weight loss has plateaued, and they're 40, 50 years old and thinking, now do I have to take this drug for the rest of my life? Or can I get off this drug and keep my weight loss off? Unfortunately, to date, almost every study that's been done by the pharmaceutical companies in particular has shown that once people come off the drug, they regain the weight. And so that's a real problem. If you go on the drug and you lose the weight, and then you go off the drug and you regain the weight, you've spent thousands of dollars, and after a few years, you're back to your original weight. And then I think the other barrier and challenge, which we haven't mentioned, but is worth mentioning briefly, is that weight loss is pretty equally lean muscle mass and fat mass. And that's very bad and very harmful to be losing lean muscle mass. And so while net the drugs are beneficial, we have to be figuring out ways to preserve that lean muscle mass. So I think these issues of compliance, and these are very good drugs, but they're not a magic bullet that's just going to overnight solve all of these problems.
And what about treating obesity in marginalized communities? That's an area of interest for me. And what are some thoughts there?
Well, I think if you mean if more diverse communities in terms of rural versus urban, or racial ethnic minorities, particularly Black and Native and Hispanic populations, and also low income communities, whatever their race.
Exactly.
Yeah, we know from many other hundreds, if not thousands, of studies in healthcare that whenever there's a healthcare innovation, those folks get the innovation the least. They receive the treatment the least. And so these individual focused, medical treatments tend to not improve disparities or even worsen disparities, because people who need them the least get them the most. And so this is for sure a major challenge with GLP-1s, because right now they're not covered by Medicare. They're not covered in many states by Medicaid. And so it's really commercial plans that are covering them, or people are wealthy or doing self-pay. And so there are pretty dramatic inequities in access.
Pat, any additional thoughts on what's missing from the conversation?
Well, I want to just reemphasize the waste concerns. I mean, if someone takes the medication like this that costs $1,000 a month, and they don't continue on therapy and reach their goals of weight loss and haven't made that change in their behavior for exercise and their dietary intake and gain the weight back, that's waste. So I want to make that really, as an emphasized point, that we have a problem here with this medication, in that it harkens back to the affordability issue. We need to eliminate waste as well, and that'll help maintain access so that we're getting the benefits that we've invested on from these medications. And also remind the listener that even if you do obtain that weight loss, if in say a year or two, and you're thinking about stopping, but you were one of those individuals that was initiated on therapy for that cardiovascular benefit, that was a 3-year study. And it could be that you need to be on therapy beyond that, but the study was a 3-year study. So the benefits were seen the most robustly for those that were on the therapy for 3 years. So we are anticipating, at least I am, that these therapies for some people may be lifetime. And so there's some thought that you need to start to plan for that in the case of, and we need to, as a society, if we're going to invest on it, expect that expense to be on the books for us.
And I'm really glad you brought that up, Pat. And that was actually going to be one of the questions I wanted to ask both of you about the duration of treatment. Dr. Mozaffarian, I knew you touched upon it a little bit earlier as well. And Pat, I appreciate you kind of bringing in the SELECT trial into the conversation. And, as we look at evidence, right, and that's how long that was, it was studied for in that clinical trial in terms of the cardiovascular benefit in secondary prevention. Dr. Mozaffarian, any additional thoughts on what's missing from the conversation?
Well, I think, what I've seen so far is, sort of a hyperbolic extreme between people saying, everybody should be on these drugs. These are amazing. These are going to solve obesity, versus people who care about lifestyle, the environment, and public health saying these are terrible. Like, we have to avoid these. Why are we prescribing these? And I think both of those are extreme views. What I think we need to do is understand how to leverage these in combination with thinking about lifestyle and environment and structural changes to get the benefits of the GLP-1s, all the good of the GLP-1s, while minimizing all of the negative long-term externalities for the patient and for the healthcare system and for the nation. And so I think one of the most exciting things, I mentioned I'm the director of the Food as Medicine Institute at Tufts. Food as medicine is not just the general notion that food is foundational to health. It is. Poor nutrition is the top cause of death and disability in our country, and it's estimated to cause directly about $1.1 trillion in preventable healthcare spending and lost human productivity. So food as medicine is not just this general notion of food being foundational to health, or an ounce of prevention is worth a pound of cure. Food as medicine is integrated structural interventions where patients are screened, identified, and treated with food as part of their healthcare plan now. And so this is things like produce prescriptions, where if you have the right health conditions and other conditions, your doctor can prescribe you fruits and vegetables, or prescribe you, in addition, beans and legumes and nuts and seeds and yogurt and seafood. And you get that at a dollar amount per month directly from the healthcare system, through a pharmacy with food, from an electronic debit card that you go spend at the local grocery store, or even through food delivery programs that are being put on by retailers. Or if you're really quite sick and can't even shop and cook, and nutrition is important and you have the right indications, people receive medically tailored meals, which is meals that are fully prepared and medically tailored and healthy, usually about 10 meals per week, or about half the meals you need per week for a certain duration of time as an indication. And so, and all of these food as medicine programs are combined with nutrition and culinary education and other behavior change. These programs, these food as medicine therapies, have been shown now in multiple studies to be effective for improving nutrition, for improving food security and nutrition security, for improving mental health and patient-centered outcomes, for improving risk factors like blood pressure and BMI and hemoglobin A1C in particular, and also potentially even in lowering net total health care costs, or at least being highly cost effective. And so what I would love to see is a combination of GLP-1s plus food as medicine programs. And so everybody who gets a GLP-1 also at the same time gets put on a food as medicine programs. And these can cost anywhere from $50, a month to up to, let's say, $200, $250 a month, depending on how intensive they are and the patient's needs. Most of the programs are at the lower end of the cost. And so you start a patient on both, and then after 12 months or 18 months, when a patient's achieved their weight loss, or they can no longer tolerate the drug because of side effects, but you've gotten that big bang for your buck of the initial weight loss, you naturally plan and titrate the patient off the drug, and then maintain them on this food as medicine program, which will help maintain their weight. Long term, the cost of the food as medicine program is a small fraction of the cost of the GLP-1. And so I think if we can do this combined approach, we will save the healthcare system, billions of dollars, and also help people get off the drug and get to a more holistic, lifestyle approach. This won't work for everybody, but I'm my rough guess from just clinical experience with other conditions is roughly a third of patients will be able to go off the drug and stay on good lifestyle with the food as medicine program for many, many years. A third of patients, may need to go after a few years. They may start to be doing poorly again, may need to go back on kind of a GLP-1 booster period for another year. And then another roughly third of patients will just fail and will need to kind of stay on the GLP-1s. That's my hypothesis. But I think this is a really interesting time in healthcare where we can start to combine these new nutrition-based structural interventions in healthcare with these new drugs to try to get the benefits of both.
That's really fascinating, and I'm really glad you brought up the food as medicine FIM programs. Right, as I think about back to our white papers as well, we talked about sort of that holistic care. It's one thing to start losing weight, right? But it's a whole other ballgame to maintain a healthy weight, but also that's sustained, but also healthy habits. As I hear you, talk about that, impact the whole patient. So, and I actually read your article. You had a JAMA Viewpoint, Journal of American Medical Association Viewpoint article. I read your publication where you sort of outline that alternative, if you will. So that was very interesting as well. So I guess, Pat, what are your thoughts as you hear all this?
I couldn't agree more with Dr. Mozaffarian that obesity and then the treatment for obesity and weight loss is more than just a GLP-1. It's your dietary intake. It's a food as medicine program, but it's also exercise. It's the need for that help. It comes with a condition in which behavioral modification is essential. And it harkens back to me for 30 years ago when we had smoking cessation products come to market and nicotine replacement. And we used a lot of individuals initiated nicotine replacement therapy, yet had trouble quitting smoking because they didn't have the behavioral modification part of the treatment, which is necessary to succeed in quitting smoking. Just putting on a patch or chewing some nicotine gum isn't going to stop that urge and that behavior you have associated with smoking. And eating is a lot the same. People have behaviors that they've created in which they feel better when they're eating and doing it. Losing weight, treating obesity is a holistic package of, and will be the future, in my opinion, the use of medications, food as medicine, and coaching for exercise, and then having that support system with you for months to maybe a year as a program, a package of care, not just here's your GLP-1 and here's some side effects to watch out for. You're going to lose weight.
Yeah, and I want to just add to that, could GLP-1s be the Trojan horse to actually start to integrate true behavior change therapies into healthcare? We're very proud as doctors about our guideline-directed medical therapy. In cardiology, we say GDMT, guideline-directed medical therapy, as in other specialties. Doctors are extremely, I think, cognizant and try very hard to follow the guidelines, and yet, certainly for cardiology and I believe for many other guidelines, before any drug should be prescribed, before almost any procedure should be done, before any device should be done, in all guidelines, the very, very first thing says, first, maximize diet and physical activity and lifestyle. So before you start blood pressure lowering, cholesterol lowering, weight loss treatments, and on, we could go on and on for other treatments. That's the first thing in the guidelines. Yet how often does that actually really happen in clinical practice? Doctors don't have the electronic tools to screen and refer. They don't have the training to do so. Even if they did, they didn't have previously, before food as medicine programs, they didn't have treatments that they could prescribe. So I think what's exciting is there's a moment here with the cost of these drugs and the side effects of these drugs combined with their promise, that now healthcare payers are actually starting to pay attention to it. And so there was a poll last year of about 80 top healthcare executives around the country, and more than half were actively thinking about food as medicine and other lifestyle approaches as ways to help deal with the challenges around GLP-1s. And that's only growing. I think that there are nutrition-based startups and other food-based companies that are now trying actively to get into this space. So ironically, the GLP-1s could be really a powerful tool to bring true lifestyle medicine into practice.
So is there support for FIM? And you talk about kind of that private space, but is it more so at the public level? Help our listeners understand that a little bit more.
So food as medicine grew out of two different streams. One was the Ryan White Act. In the 1980s, Ryan White was a young hemophiliac who contracted HIV and died of AIDS before there were any treatments. And so the Ryan White Act was passed to help patients who were dying from AIDS when there was no treatment get what they needed and sort of palliative care. And so it through by law allowed healthcare to pay, among other things, to pay for healthy, nourishing meals because people were wasting away. And so that started this process of medically tailored meals. And when triple therapy and other therapies for HIV became available, and this became more of a chronic disease, those nonprofit, faith-based, community-based organizations started looking at other populations, heart failure, end-stage renal disease, uncontrolled diabetes, to give medically tailored meals. On the produce prescription side, food as medicine started with more the food security programs like SNAP, the food stamps program, and nonprofits, community-based organizations trying to help low-income Americans get more for their money for healthy food. And so things like double up bucks or other ways to spend their food stamp dollars and double the money when they could bought fruits and vegetables at a farmer's market or their local grocery store. And then they started seeing health benefits and started seeing that the patients liked it, the farmers liked it. It was kind of win-win. It helped strengthen the local agricultural food system. And so that has produce prescriptions became popular. I give you that history because this started in sort of the community-based field, plus with the Ryan White Act in healthcare. And now there are now private sector startups, as now this is starting to be covered by Medicaid in multiple states. This is covered by Medicare Advantage programs. This is covered under in lieu of services and other exemptions. Food as medicine is starting to be covered by commercial plans. As there's more and more funding for these programs, now you have a kind of a smorgasbord of private sector companies like Territory Food, Season Health, Instacart, others doing food as medicine, and you have still the community-based organizations doing food as medicine, with pros and cons of each. And so we're in this kind of fluid growth phase where there's a lot of interest, I think, in food as medicine. And right now it's a combination of local community organizations and larger national for-profit companies providing and delivering these services.
And I believe there was a White House conference around food as medicine recently as well.
Well, in 2022, President Biden, along with bipartisan leadership from Congress, from both the House and the Senate, hosted a White House conference on hunger, nutrition, and health. And this was the first time in more than 50 years that the federal government at the highest levels focused on hunger, nutrition, and health. And a national strategy was produced from that conference that all the agencies now are actively implementing, and Congress is actually actively supporting, including in many of the proposed bills coming out of the Democratic Senate and the Republican-controlled House. Right now, these weeks, there's many food as medicine things in those bills. So both Congress and the White House are pushing forward food as medicine, which is one of the pillars that came out of the national strategy. And with everything going on in politics, with all of the noise and distraction and arguments, there is actually a lot sort of happening quietly in food as medicine and successes that are happening. The Veterans Affairs Hospitals has food as medicine pilots that are growing. The Indian Health Service has food as medicine pilots, which are growing. The Department of Health and Human Services has a food as medicine strategy they're building. There's an interagency working group that's building and expanding food as medicine approaches to health. So there's actually more and more going on that most Americans haven't heard about, but is very positive.
Yeah, that's really interesting. And is education, or I guess training for healthcare professionals, an aspect of all of this? As I think back to pharmacy school, right, or when I did my clinical residency, we didn't really focus on FIM, right, as part of my training. What does that landscape look like today?
Well, that's what got me into this field, is when in medical school, residency, and cardiology fellowship across all of those years, I barely learned anything about nutrition, but saw it was so important for my patients. That was the great irony that got me into my research field. So we and others have really been advocating for advancing nutrition education for multiple allied health professionals across training. So both in school, in specialty training programs, and then in once somebody is in practice through continuing medical education, other things. And I think in systems. So I think the way to do this is to change the system, and it's pretty simple actually. It's not rocket science. If we change the accreditation requirements for the schools and the residencies and fellowship programs, and if we change the tests, for doctors, the U.S. medical licensing exam test, and then the various specialty board examinations, the American Board of Internal Medicine, others, and then if we change the CME requirements at the state levels, which is at the states, to include nutrition, you change medical education overnight. And so we're not talking about doctors and pharmacists and nurses becoming nutritionists. We have RDNs, and they're an extremely important part of the healthcare system. But I need to know as a cardiologist when and in whom do I order a cardiac MRI? How do I interpret the results? I don't need to know how the MRI machine is built or know all the details of all the physics, but I need to know enough to use the tool. Similarly, doctors, pharmacists, others need to know about enough about food as medicine to screen, refer patients. And so the ACGME, which is the accreditation body that accredits all of residencies and fellowships, publicly announced at our summit last April in Boston that they are moving toward the process of potential mandatory nutrition education for all residencies and fellowships, which is an amazing shift. That would if it moves forward as planned, would start in 2026. The AAMC, which accredits medical schools, has not yet made the same announcements. And I'm really hoping they should. And I know that there are members of Congress who are very, very interested in this. And I'll just end by saying the House, in their recent appropriations bill, included very specific language calling on all of these accreditation agencies and all of the specialty board exams to integrate nutrition education into their standards.
Yeah, sounds like some really promising developments in that space. Thank you so much for educating us on and our listeners on kind of what's going on with that landscape. So as you think about FIM, right, and we talked about the SELECT study, Pat, you mentioned that earlier. How do you, if you were to stratify patients, Dr. Mozaffarian, think about the label, you talked about guidelines, right, and what guidelines recommend in terms of what's the cornerstone of therapy in terms of, starting with lifestyle modifications. How do you stratify to achieve positive outcomes for patients when you think about GLPs and how would you approach that in terms of the stratification?
Well, I think right now coverage and cost, unfortunately dominates over clinical judgment, right? Because they're not available for everybody. And so unfortunately, we can't have a kind of a more rational approach. But I think ultimately, the rational approach would be to obviously start with the highest risk patients who have, more severe obesity and or more severe diabetes with multiple risk factors, and combine their GLP-1 therapy with food as medicine. I think for patients who are less severely ill, maybe this you start with food as medicine. And then I think for the general population, we obviously have to start and change the environment. And we have an active policy initiative doing policy research funded by the NIH and many others, and also advocating with Congress and the agencies to do a lot of other things to help kind of improve the food system. So I think that will be developed. But I do want to just mention, for people that are interested, I think a really interesting area of research is what naturally increases GLP-1 levels. The GLP-1 hormone comes from the gut in response to food, which we didn't talk about. Like that's actually where it comes from. The natural stimulus is food. And so do we know anything about foods that might, augment that GLP-1 release, and foods that might blunt it? And we do. There's some research, very early, but some interesting research. And so things that seem to blunt GLP-1 production, which would be a bad thing, interestingly, added sugars and artificial sweeteners in some experiments seem to blunt GLP-1 production, and also foods high in saturated fat. And then things that seem to augment GLP-1 production, healthy fats in particular, healthy plant-based fats, so avocados, nuts, flaxseed, olive oil, have all had early science suggesting they augment GLP-1 production. Prebiotic fibers, so all kinds of healthy fibers that nourish the gut microbiome, things like beta-glucan and oats and rye, oligosaccharides in beans and peas and lentils, pectin in apples and pears and green bananas, and even some other high protein foods like fish and eggs seem to augment GLP-1 production. And so while nutrition will never give you the levels that a drug would give you, I think that's a really exciting area for future research is, what are the foods that augment GLP-1 production, and what are the foods that blunt it? And I'm guessing, and you could probably tell from the list of what we know so far, that it's probably pretty consistent with what we know already about what's a healthy diet and what's an unhealthy diet.
Yeah, we could certainly have a whole hour podcast just talking about the various foods. I'm so glad you brought that up. And when I was, again, thinking back to our white paper, that evidence piece was one of our pillars. So looking at the food piece also through that evidence lens, and some interesting, hopefully, research to come in that area. So we're heading into lunchtime, at least on the East Coast, for those who are also listening. And I'm going to have to think twice about my food choices at lunchtime. But any favorite foods that you guys like, or any cheat foods, if you will, that you like to occasionally indulge in?
I'll be in Minnesota, and in the hot summer, that Dairy Queen blizzard is something that's hard to avoid as a cheat.
Well, I'm going to sound like a crazy nutrition guy, but all of the foods that taste great are also really good for you. And if I eat something that I think, or I remember from my childhood tasted good, I feel sick afterward. And so I've learned to stop eating those. And so for me, things that taste good are also good for me. Things like dark chocolate covered nuts, things like a healthy ice cream loaded up with fruit and nuts, a great dinner with salmon and, grilled vegetables and olive oil, extra virgin olive oil, and a really nice, small piece of sourdough bread. The challenge is most Americans can't afford and don't have access to that kind of food. And so my mission is to make it so those healthy, delicious, nourishing foods, are widely available and accessible for all.
I love that. And then how do you stay active?
Well, I've recently learned Tai Chi, the Qigong form, which helps me both mentally and physically.
That's really interesting. Are there different forms of Tai Chi?
Yes, there are. And being a novice, I can't name them all, but I'm partaking in one form.
You know more than I know. That sounds really interesting. Yeah, that's wonderful. Good for you. Dr.
Yeah,
Mozaffarian, how about you?
Yeah, I mean, for me, exercise is like the natural high, and so if I don't exercise for just a few days, I feel really notice it. And so I was a college wrestler and did a lot of other sports over time, but about 15 years ago, I picked up Taekwondo, and that's I would say my main exercise of choice now. Although I do other things, swimming and skiing and other things with the kids, but Taekwondo is a really terrific way of keeping in shape that also engages the mind and kind of engages the spirit.
That's fantastic. And how far along, I guess, are you on your Taekwondo journey?
I recently tested for my 4th degree black belt, and so I'm a 4th degree black belt now.
Wow, fantastic.
Congratulations.
Thank you both for taking the time to talk with me. It's been a pleasure learning from you. Really appreciate your insights, the informative and really important dialogue. And so I really appreciate all the insights today.
Yeah, thank you for your leadership, Maryam, and for hosting.
It's been a pleasure. Thanks, Maryam.
Thank you for listening to this episode of Pharmacy Friends. If you'd like to listen to more insightful conversations about what's happening in pharmacy, visit our website,